All right, I think we're at time here to get started. So hi, everyone. Welcome to this session of the 2023 Culture of Data Conference. We're really excited to have you all with us. I'm Jessica Stoker, she, her, and I'm going to be moderating this session. And we also have Samantha Bertoman, who is managing the Zoom and really just making sure everything's running smooth tech-wise. You're all muted now, but if you have a question during our Q&A sessions, please feel free to put them in the chat or come off mute. And if you're comfortable doing so, please feel free to add your pronouns to your Zoom name by clicking the three little dots up near your video square and selecting rename to add those. This session has really been generously sponsored by Champ Software, so we thank them for their contributions to this conference, and we'd like to introduce David Smith from Champ Software to share a few words with us. I believe they have some slides, so we can take the slides off and let them share.
Good afternoon. I want to welcome you to this session, and I'm just going to share my screen here. Hopefully you can see that. So my name is David Smith. I work with Champ Software. I've been working with local health departments for almost 20 years now with Champ, and I'm just going to talk a little bit about what we do. So CHAMP, the company name, is an acronym for Community Health Agency Management Program. And we like to ask, when we're dealing with agencies, where on the continuum of the evolution of public health documentation do you find your agency or your organization? Are you still stuck partly in the Florence Nightingale era of 100 years ago to the turn of the century here? Are you using that with spreadsheets? Are you using data silos? And 95% or more of the public health departments we're working with are right where this blue arrow is, stuck between Public Health 1.5 and 2.0. We want you to know where CHAMP's at. Since 2011, we have built the technology to support all the goals of Public Health 3.0. And so we can help you accelerate your pathway as you head that way. We want you to know that we are Public Health 3.0 ready, and that we can help you measure and advance public health equity. We're really excited to be at this conference because data is a really big thing for us, and it has been since our beginning. We have a philosophy of comprehensive agency management. So some people think they're looking for an EHR, which we certainly have, but we do a little bit more than that. We want to track and manage all your activities, whether your clients are individual people, households, or family groups, non-family groups, the community or systems level impact. And again, like I said, most people are looking for an EHR, and we do have one, 3 levels of documentation, built-in measurements and outcomes for social determinants of health. We can produce things like child growth charts tied to the percentiles of the WHO organization and CDC. But we offer a lot more than that. And you can see one of the biggest areas for us is data management. So we were started by a public health administrator. We have been expressively public health for the 37 years we've been working with public health departments. And so we can help you manage your data, get out what you put in. We're in 13 states across the United States. We're surrounding Colorado there with 3 states that are using our software now. The other thing is we can collect data from any and all your programs. Our 170 counties that use us today are doing documenting their encounters and collecting data and getting data back out of 80 various public health programs, all the way from community health initiatives to walk-in clinics, reproductive health, school-based health, those kinds of things. Our philosophy is we must move from just collecting data to using data. We must convert that quantitative data into information, knowledge, and wisdom so that we can turn it into actionable data. Our clients say this about us: provides real nice data I can go get funded with. If we don't show the benefit of our public health programs, we're going to get left behind. In other words, we might lose funding. And then the third thing is the data that we provide or allow you to collect and access helps you get documentation for evidence in domain 9 for accreditation. We believe that we should be giving you back actionable data displayed in 100 different ways so that you can write your own success story. We do have 3 different packages with features for you. And again, CHAMP software is a community health agency management program, so we're a lot more than an EHR. We'll have links in the chat, and you can contact us if you're interested in learning more. Thank you for having us.
Wonderful. Thank you so much, David. All right, so today we have two presentations, and each one of them is going to be 20 minutes with 10 minutes then for Q&A afterwards, and we're going to take a 5-minute break in between the sessions as well. So the theme of this session is really new directions for local public health, the backbone of our public health system. And we're going to explore preliminary findings from a local public health data system and capacity assessment and innovative data well, I'm sorry, goodness, I can't think and speak. Innovative data practice that's engaging community members with data outcomes. So our first presentation today is Data Systems and Capacity Assessment of Colorado's Local Public Health Agencies, presented by Cara Bradbury, Cassi Niedziela, and Rachel Artz-Steinberg. So we will hand it over to you all.
Great, thank you. Yeah, thank you for the introduction. We're excited to be here, and we're excited to present on some of the preliminary findings that we've gathered over the past few months with local public health agencies. So really quick, we'll tell you who we are. I'm Cara Bradbury. I'm the Executive Director of the Colorado Association of Local Public Health Officials. We are the association representing all what is now 55 public health agencies in the state of Colorado. And then I have two colleagues with me. Rachel, do you want to introduce yourself?
Sure. Hi, everybody. My name is Rachel Artz-Steinberg, and I work as the Community Improvement Analyst for Colorado Community Managed Care Network.
Great, and Cassie?
Awesome. So my name is Cassi Niedziela, and I'm a project coordinator for care coordination and social health information exchange in the Office of eHealth Innovation, which is housed within the Office of the Lieutenant Governor.
Great. Yeah, so we're excited to have come together and worked with this group to really start to explore how we can do data modernization at the local level. So as a little bit of background, I will share that I'm sure many of you know, working in this space, that there's been kind of a renewed focus on public health data systems, and particularly around surveillance systems for disease, communicable disease, but also just chronic diseases. And so as a kind of foundation, I wanted to share a little bit more about the CDC's public health data modernization effort. So at the kickoff of the pandemic in about 2020, the CDC came out with a data modernization initiative strategy and have subsequently allocated over $1 billion to this strategy nationally. Oh, sorry, I wanted to look at some notes, but I guess it won't let me do that and have the slides at the same time. So, so the data modernization effort at the national level has 5 different components. The first is really around building out the technology and the systems themselves, and really striving towards better quality data collection and interoperability. The second is really around the workforce and building out a competent sort of state-of-the-art workforce in this space. The third is really about building partnerships and working with kind of unusual suspects in this space, and you know, starting to do better data sharing amongst not just public health but healthcare partners. And then hold on, I'm going to have to escape out of this because I had notes over here. The fourth is the analytics piece. So improving the ability to do analytics on all of the data. And then the fifth is managing the sort of governance of data. So that's the way that the CDC is breaking down their data modernization work at the national level. And this work got us thinking about how do we leverage this model and these investments at the local level for public health. We've seen a lot of dollars come into the state of Colorado, and there's some really exciting efforts happening at CDPHE to modernize data systems and build a data lake that will be able to absorb a lot of different sources of data and do analytics. But we were starting to kind of wonder, like, how will this impact LPHAs? How can we have a seat at the table and ensure that that investment trickles all the way down from the top. So in that vein, we kind of came up with a framework to think about how to approach and learn about what was currently happening with local public health agencies. And so we kind of split up this big bucket of data, like what do we mean, into these 3 different categories. The first is that local public health agencies are data system users, and many times those systems are kind of delegated to them by the state. They don't necessarily choose the systems, but they are told, okay, as part of your grant funding or part of your activities, you're required to use this particular disease surveillance system that's owned by the state. And so we wanted to understand how's that working for them. You know, what can we do to ensure that they have a seat at the table, that they're getting, that they have an understanding of what data is being collected and how they can use it, and that those tools are working well. The second bucket is really around data, LPHAs as data collectors and owners themselves. So we know that many, well, all of the LPHAs do community health assessments. And as part of that process, they go out and collect data from their community members and then use that data to inform their strategies and their ongoing investments and activities. But some of the challenges is that there's not a lot of consistency across LPHAs. So much of that data cannot be rolled back up into a broader story to be told statewide about what's happening. So that can create some challenges for advocacy organizations like CALPHO that want to be able to tell a good story about what the challenges are and where we need to make more investments at the local level across the state. The third area is really around LPHAs as individual care providers. So we know that many LPHAs are providing critical care in their communities, immunization, family planning, different services. And so as part of that, they are, collecting information and have an opportunity to participate with other care providers in their community to do better whole person care coordination. And that kind of necessitates the ability to collect that information and have interoperability with those other systems. So not all LPHAs currently use an electronic health record. Many do, but some still are using paper filing. And that can make it really challenging to do quality improvement or to coordinate with other partners. So trying to kind of understand where LPHAs are where they're at on that continuum. So that was the big framework, kind of the universe, if you will, of the way we were thinking about how do we understand how local public health agencies can improve their data collection, analysis, and use, and how can we leverage. So then that from there got us thinking, how do we kind of bring these 2 things together and leverage what's happening at the federal and state level while making progress for locals. So that laid the foundation for the partnership that I just described between CCMCN, CALPHO, and OeHI. We all came together and decided to conduct key informant interviews with local public health agencies. We're interviewing 18 different agencies across the state from a variety of regions, backgrounds, sizes. We developed an interview document that had categories or questions in 3 categories around kind of their existing strategies and priorities, barriers and pain points, and then kind of the ideal state, recognizing that the LPHAs are going to fall probably on a continuum. And so we have to figure out how to meet LPHAs where they're at. So we're not totally done with this process, but we saw the Culture of Data conference come up. And so we thought it was an opportunity to raise awareness that this was happening and share some of our preliminary findings. So the final report won't be done until June, but we're here to share some of the initial responses that we've got. So I'm going to turn it over to Rachel, who's going to talk about what we've heard so far.
Wonderful. Thank you, Cara. Yep, as Cara mentioned, we've been meeting with local public health agencies throughout Colorado over the last 6 months or so to understand more about the role of data and how that how data plays a role in their day-to-day activities, and how data use and access could be improved to better support their needs and priorities. So I'm going to share with you some of the trends and themes that we're hearing across the state, and include some impactful quotes from our interview participants that really illustrate these findings. The first is a need for streamlined data storage and analysis within each LPHA to aid in understanding a more holistic view of the health of their community. Oftentimes data on individuals exists in various systems, often tied to outcomes specified in grants and programs that are supporting that work. And it's difficult or sometimes impossible to extract that data in a standardized way and then match it across data sets to understand a larger picture from both a programmatic and community standpoint. And as we know, this can lead to duplication and fragmentation of services. One participant said, "How do we compile data from programs that are serving similar populations? For example, we have 3 separate home visiting programs. Our guess is that we are seeing similar themes across all these places, but it's extracting it and overlaying it to say these are some things we are learning about new families in our community, and that can guide our actions so we aren't picking and choosing between programs' data. It is the ability to extract and compile versus these siloed program data collections. There's a ton of data, it's just really hard to take it out and put it back together again to make sense." The second need that we want to highlight is the need for LPHAs to have a centralized space to access data in order to understand what data is available at community, state, and federal level in order to aid in developing programs for the populations that they serve. There's variability across the state, as you can imagine, in the way that LPHAs understand the availability of population health data and how to access data for their communities. One LPHA said, "The ability to consume data in an efficient and standardized way is a barrier. Every system has its own unique way of accessing data. That is a challenge." The third need that we would like to highlight is the need for regional versus county data sets, which is a critical distinction that can be prohibitive to addressing health trends and disparities. Many LPHAs have to receive and analyze data sets at a regional level, meaning 2 or more counties combined. This is due to numerous reasons cited, including too small of sample sizes to be statistically significant, and then redacted data due to privacy constraints. This is problematic because it hinders LPHA's ability to understand the issues that community members are facing and how to address them. There's variability in different geographical areas of communities, and it is important for LPHAs to understand these nuances and how to create programs and services to address those. Additionally, access to real-time actionable data sets to inform acute decision-making and aid in timely community collaboration was also highlighted as a need in numerous communities that we spoke with. There's a time lag in the acquisition of most population level data, and many LPHAs do not have access to real-time data sources. One interview participant stated, "The biggest challenge locally is the need for real-time data to inform decision-making at a county level. It's secondary data coming from methodologies from the early 2000s, like gathering info through phone surveys. But then it's hard to pull out data for our county specifically because the confidence level is so large. As you dive into it, it's hard to show accurate numbers and knowledge, attitudes, or behaviors. We need data that's not 3 years old to tease out both at a population and individual level." Let's go to the next slide, please. So some additional themes that we found throughout our interviews are highlighted here. So workforce recruitment and capacity has been challenging for many LPHAs seeking to recruit and retain staff with specialized skill sets in their communities, such as data analysts, epidemiologists, registered nurses, and other provider types. The cause of this has been attributed to national shortages in these professions, as well as lack of resources to attract relocating individuals and their families to these areas, including affordable housing and childcare. One LPHA stated, "Right now we have 3 public health nursing positions open. One has been open for 3 years and the other 2 have been open for 2 years. It's just been super challenging." And another said, "We struggle on a daily basis with staffing. We've had 3 nurses in the immunization position in the last 2 years, and I don't see this trend changing." Additionally, another participant stated, "A lot of LPHAs don't have the support to house that many data folks. And so when I talk to staff at other LPHAs, they are wearing a lot of hats. A lot of positions require specialized skill sets, and it's difficult to maintain or develop these positions when you're so busy all over the place. Data people aren't cheap, and they tend to cost more than typical public health staff." Another trend we heard was the need for increased funding and stability. One LPHA stated, The smaller counties are on the brink of bankruptcy. How can they get server space to help build the system? It's like every county building their own electrical system. You'll get very different outcomes if they're all in charge of building their own. Another stated, we need to regionalize more equitable with resources. Finally, long-term training and support was mentioned as something that LPHAs would benefit greatly from. One LPHA stated, the motivation to believe data and interpret appropriately is essential. You need administration that understands the importance of data. Another said, there is some kind of communication gap with what data we have is safe and what is not. They're scared of data and we need to break down the barriers of understanding. Additionally, another LPHA stated that we need more frequent interagency collaborations with nearby LPHAs to see what they are doing. Now we're going to hear from Cassi about potential solution areas and opportunities to address some of these findings.
Awesome. Thank you, Rachel. So as Rachel mentioned, I'll be discussing our potential solution areas and opportunities, which we've divided into 3 categories here. And these solutions are all from a state perspective and things that are either already underway, currently being planned, or should be addressed moving forward. So the first bucket here is data sharing. And the first thing here is increased coordination of state and local data systems to support whole person care. And so one way this is being addressed is through the state's active negotiation with vendors to build a statewide social health information exchange. And so the aim of this solution is to seamlessly integrate physical, behavioral, and social health data from existing systems to support better quality whole person care, as well as compile analytics and insights from this data so that it can be used and contributed towards better population health. The next thing here is clarification of public health authority. So several LPHAs mentioned that it's challenging to share or receive data from different like local providers or community partners due to a lack of knowledge about what can and cannot legally be shared, just kind of out of fear of violating different state and federal protections. And so the state can work with LPHAs and different health partners in the community to clarify the understanding of what data is actually permissible to share, as well as different information about information blocking rules and the Cures Act and things like that. And finally here we have standardized data use agreements. So many LPHAs have reported that when community partners are able and do agree to share data, it takes a lot of administrative time and effort to negotiate the terms and conditions for sharing that data before the work can actually begin, which hinders a lot of data sharing. Moving on to state relationships, we heard from a lot of folks that there should be increased clarity of state communication in kind of 2 different main buckets. So 1 being who to reach out to at the state for questions or support, and then 2 just being more timely and increased communications about upcoming changes so that folks can make preparations in advance if necessary. We also wanted to touch on collaborative system development. We should be ensuring that systems are developed with the LPHA end users in mind and at the table so that systems are useful and don't waste time and energy of any party involved. We also wanted to touch on some different state programs to mitigate financial barriers for LPHAs, such as improved program coordination to reduce administrative burden of LPHAs so they're not reporting the same data in 5 different ways to 5 different state systems. We also talked about increased state technical assistance and support for data collection efforts, as well as ensuring that communities receive something for their data collection, or in return for their data collection, excuse me, either financially or through useful reports or insights to make sure that data collection is providing value and not just ticking boxes. And finally, here we have amended data collection strategies because many population level surveys often fail to capture regions or populations with lower population sizes. And so the state should be exploring some different methodologies to ensure that we have accurate data on all of these very important populations. And we want to make sure that insufficient data is not a barrier for communities to access the resources and supports that they need to thrive. And finally, I know we're almost out of time, we have public health collaboration. So we heard from many LPHAs that they would like to have more forums to collaborate with other LPHAs, not necessarily in conferences, but maybe just more like regular convenings and just ways to learn from each other and brainstorm different projects and paths forward together. And finally, increased professional development opportunities for things like training, such as like data analysis, qualitative research, etc. So the state will be working, or OeHI will be working with CDPHE and CALPHO to discuss what this might look like, and we're open to suggestions from the audience as well. And then finally, also the state should offer additional technical assistance for those with limited resources or technical capacity. I'll hand it back to Cara.
Thanks. Yeah, so just to wrap us up really quick. So what's going to happen next? Actually, a couple exciting things are happening. CDPHE, which we should have mentioned at the outset, we've been working closely with CDPHE, and they are in the process of hiring a data modernization director. And so they are going to be staffing up with that individual. And then the other exciting thing is that they are supporting CALPHO to also hire a data modernization director who will be focused on local public health. And so we're excited that we'll have an individual at the state level and someone at CALPHO who can really help to kind of act as a liaison to the state to continually elevate the needs of LPHAs in this kind of bigger picture. So once we have our data modernization director on board, and the job is actually open right now, so I will put the link in the chat if you know anyone or you're interested yourself, please apply. It's still open. It says the 31st, and we're starting interview process, but if you know someone good, then please tell them to apply. So and then we'll actually be bringing on 2 additional positions to support our kind of data modernization project team at CALPHO. And yeah, so we're really excited about that. We're going to be developing a roadmap and really focusing on how can we actually get some of this done by convening and providing some kind of coordination and backbone capacity to this effort, specifically for local public health. So that's it for us. If you have access to the slides, which you should, you'll have our contact information. Please feel free to reach out to us. We really are excited to hear about what people think about this. And I will put my last plug in, which is that we're also going to hold kind of a mini data summit specifically for local public health staff in June. So that'll be kind of a rollout of our final report and start to kind of develop some planning with local public health agency staff. So thanks. Excited to hear what you guys think or answer any questions.
Wonderful. Thank you all so much. Some really interesting information that you all learned from local public health agencies. What questions do folks have for our presenters? Feel free to come off mute or put things in the chat. I'll kick it off. These seem like such big issues and like a really exciting work to think about that folks are going to start kind of trying to look at. I'm curious if you can talk a little bit about if there's been any discussion around like the funding piece of it, just because there's so, I mean, it seems like these are pretty like big long-term projects that could kind of be taken on. So curious if CDPHE and I'm sure OeHI as well, like thinking about where funding might come from to support this kind of work. And it sounds like you already have like new data folks. So that's pretty exciting to have people who are specifically looking at this, but curious if you can talk a little bit about the funding pieces that might need to be found, or maybe they're already underway.
Yeah, it's a totally fair question. There is funding that's coming to the state. So when I go back to that framework or those big buckets, so there's funding that's coming into the state to do some pretty significant change, to create some pretty significant change to the surveillance systems that the state owns that really impacts local public health and has the opportunity to improve local public health. And so I don't know the exact dollar amount, but millions of dollars, right? And so having this individual and this plan in place will hopefully allow us to leverage those funds and those activities to say like, hey, this is how those changes are gonna, how we could, you know, because like they're kind of shifting from their current softwares over to a new one and say like, well, okay, this is the functionality we want to see, or can you build in these types of analytics capacities so that we can use that for our purposes at the local level. So there is that piece. And then CALPHO has this what will ultimately be about 4 years worth of funding to bring on a couple people that will provide technical assistance to local public health agencies. But you're right, like there's never enough money to go around. There's like a lack of funding that generally trickles down to like local agencies. And so one of the other things that we've been talking a lot about is how do we either push the state or even potentially CALPHO to be like a centralized purchaser of technology platforms that everyone can have access to. And we're already piloting one example of that, which is well, there's actually 2 examples right now that we're kind of going to be piloting. One is access to journal. It's a little less relevant, but journal entries. So the state said, hey, you know what, it's cost prohibitive for all of the agencies to buy their own access to this like journal, like public health journals and things like that. So we're going to buy this access so that everyone can go in and have like the most up-to-date kind of poll research for public health. And the other thing that we do have funding for is another project that's funded through the CDC that's called the Local Health Department's Academy of Science. And it's a similar concept around developing shared measures. And so we have some funding to say, hey, if you want to join this pilot with us and you want to use the technology, we'll pay for it and the state will own it. And so those are some other ways we're trying to think about like reducing the cost for LPHAs. But I don't know, I know I'm sure that we will do a lot of like piecemeal. And Cassie, you might be able to talk about some of the revenue streams that you have that we might be able to kind of bring to bear.
Yeah, and those were all great examples, Cara, so thank you for sharing those. The one thing I wanted to mention from the OeHI perspective, at least, the Office of eHealth Innovation, so the Social Health Information Exchange that I mentioned, or the SHE, so that's currently in active negotiation, so I can't share too much, but we are envisioning that will be a statewide unifying architecture as well as smaller regional work, where we have like several $1 million set aside for the regional work. Where money will go directly to communities and to community organizations to kind of build up that technical infrastructure that they'll need to connect to the statewide unifying architecture. So that's another way of just kind of putting money out there for the communities.
That's amazing. Thank you. What other questions do folks have, or maybe reflections? Does this resonate with you as far as your experiences? Anybody in local public health or even state seeing or hearing similar things? I know we're getting close to the end of the day. Starting to feel it. Should have had another cup of tea before the meeting. I'm wondering too, so you mentioned somebody's quote, which made me think, so I work for CDPHE and in early childhood though. So I'm wondering if you could talk a little bit about integration with other state agencies or other programs, because somebody mentioned home visiting, which we work with, but I know that's run out of CDEC. So curious if anybody can talk a little bit too about your integration with other state agencies too, obviously OeHI and CDPHE, but other programming, early childhood, especially potentially.
Yeah, I can start with that, and then Cara and Rachel, if you have anything, please do jump in. So my work specifically, I haven't worked too much on like early childhood programs very much, but I would say that our social health information exchange and care coordination efforts, we've been working very closely with HCPF, which is the state Medicaid agency, as well as the behavioral health agency, to make sure that that data is integrated as well. OIT for kind of the technical support there, of course CDPHE as well. So we definitely try very hard to convene many different people, and we have the eHealth Commission as well, which brings in stakeholders from different community organizations or state agencies as well each month. Yeah, I don't know if that answered your question, Jessica, but yeah.
we may have some more time. I just put this in the chat, but just if anybody thinks of something as we're going on here, please feel free to put it in. I see one came in. Have you thought of use of a standardized language for help with gathering standardized data at the state level? Good question.
Yes. So one of the areas that we're interested in exploring is an effort that I just mentioned called the Local Health Department Academy of Science. That's an effort that CDC has been funding over a number of years. Conceptually, what it is that you convene health departments to say, it kind of was born out of this problem that health departments collect different information, oftentimes on the same subject area, right? So they go out and say, we want to do a community health assessment. We think that mental health is probably a significant problem, so we're going to ask community members, but they use different language and they collect information in different ways. And so when they get done, you might look across the state and say, well, gosh, 38 out of the 55 agencies have mental health as a top priority in their community health assessments. But when we dig into the data, we can't actually say how can we compare or contrast or to articulate what's happening here. And so we want to start a conversation where we convene local public health to say, can we agree on some common measures? And by measures, I think that's analogous to you saying standardized language. At some level, we're talking about the same thing. Can we agree that we're going to collect data and ask, a question in a similar way around how many poor mental health days have you had in the last month, so that we can actually start to tell a similar story at the state. And for an advocacy organization like CALPHO, we need this information so that we can go and say, here's the size and scope of this problem, and here's how local public health agencies are addressing it. And yeah, so definitely going down that path right now.
We got a suggestion is holistic in nature is the OMAHA system. Do you want to say, oh, go ahead, Cara.
Are you talking about their social health information system, or is it a public health system? I'll have to look into that more. Okay, standardized nursing language. I will look into that. Thank you.
All right, well, thank you all so much. Thank you again to our presenters. We're going to go ahead and take a 5-minute break. So we will be back at 3:27. Please feel free to get up and stretch, do whatever you need to do, and we will be back shortly with the next presentation. Thanks all.
Thank you.
Thank you.
All right. Welcome back, everyone. We'll go ahead and get started here with our next presentation. Thank you to Cara for putting those links in the chat for the job openings that you mentioned. So our second presentation is Data Pods, Communities Taking Action with Their Own Data, presented by Rebecca Larson and Erin Seedorf. So we will hand it over to you both. Thank you.
All right. Good afternoon. I am Rebecca Larson. I'm the epidemiologist and deputy director with Eagle County Public Health and Environment.
Hi, and I'm Erin Seedorf. I'm an assistant faculty member at Metropolitan State University of Denver. I'm working on this research project together with a very large and rich group of community partners, and MSU is supporting some of the evaluation components to this project.
Yeah, so as Erin mentioned, we're talking about data pods, and we kind of first started with data pods as part of an Advancing Health Literacy grant. It's a federal grant through the Office of Minority Health. We're just finishing up the last few months of this project. And really the project was focused on better understanding optimal engagements between our healthcare professionals and our community members who identify as Black, Indigenous, and people of color in a 4-county region, including Eagle County. So project goals were centering our BIPOC community voice and power within the project, optimizing those engagements in a healthcare setting, increasing BIPOC community members' confidence in communicating with healthcare professionals, and then kind of where we're focused on right now is reimagining community participatory research and evaluation, focusing on equity. And so this grant was really focused on the need for community input and voice in pretty much the entire stage of the project. But we're going to talk about kind of the evaluation and dissemination of data, where that also plays a really key role to make sure community has input in interpreting that data, but also how it is disseminated. And then I'll probably chat a little bit. We're also using data pods in our local community health assessment and public health improvement plan process. So we're planning to implement those this summer.
Perfect. So just kind of to set the stage, really, in any research or data collection project, we know that there are literally hundreds of decisions that individuals make throughout the process. And in each of these decision-making steps, there are people that are involved. And so the people that are involved probably bring some particular experience or context. We know that, the very basic tools of statistics and data science don't inherently carry bias. However, as soon as we start to get people involved, that's when choices start to come in and bias can be infused into that process. So if we don't examine bias from the beginning and reinforce, our looking at our own perspectives and how that affects data, then we're looking at making decisions that are based in context and not in a particular context, and not necessarily the context that we're intending when we're centering on equity. So in a community-focused project, we want to make sure that, as Becky mentioned, community is actually placed at the center of all of the decision-making points, whether that's directly engaging the community or at least prioritizing that voice in the consideration of each decision. So for this project, we took on, and this was for the whole project, we took on a framework called the Data Equity Framework that we've really felt is helpful. The Data Equity Framework is a framework that's been developed by an international research organization, We All Count, and it's a systematic way of looking at data projects. So what it does is it organizes every project into 7 stages. Those stages are funding, motivation, project design, data collection and sourcing, analysis, interpretation, and 7, communication and distribution. So in each of the steps in this framework, researchers are provided with tools that help analyze the decisions that are being made. And it's causing us to think about questions like who is making the decision, who has the power, and who's affected by the decisions that we're making. So the data equity framework provides direction for research teams to make those choices and to be intentional, so that we're achieving the data equity goals or the equity goals that we've intended in our work. All right, next slide. So for this project, or even more specifically for this presentation, we're going to focus on 3 steps of the framework, which are analysis, interpretation, and communication distribution. So these steps are really critical in what we have been designing in our data pod process. We're going to describe that a little bit more specifically in upcoming slides, but I want to give you the context of these 3 steps in the framework because I think that's important. So starting with analysis, the framework presents that, in any analysis process, we often find a very small group of data workers who are making lots of decisions, and these decisions aren't often understood by the larger group, and specifically not often understood by the people that we are trying to reflect in the exploration of their experience. So while we do need data analysis expertise, we also need a system to make sure that those decisions are transparent, that they're intentional, and that they're connected. They're not connected to any particular analyst's kind of perspective or experience. So then moving to the next step, we look at interpretation. And interpretation is really the step in trying to provide useful and meaningful explanation to the results that we're seeing in our data. However, we know that in providing meaning to data, that often adds subjectivity to the process, right? But interpretation should be a combination of a few things. So it really should think about our best understanding of the limitations of our data, right? Being very transparent in that. It needs to be very intentional in thinking about how we're interpreting and the process that we're doing that. And then it needs to be, again, the methodology and the content, we need to strive to center around the community voice in that process. So interpretation is really one of the key aspects that we've infused in our data pod process. And then lastly, we are looking at communication and distribution or dissemination. So just curious, I'm sure everybody's heard the phrase, the story's only as good as a storyteller, right? So this is completely true when we're talking about communication and disseminating our research. So we need to be clear on how we center community and equity in developing communication of our information and then in the process of distribution. So within the data equity framework, it provides a series of things to help us match our communication content to the design of how we're just creating that content, the medium that we're using to choose, and then the accessibility or the process of actually releasing that information to our community. And in all of that, in all of those pieces, there needs to be a reflection of equity in the process.
All right, so before we kind of start breaking down what are data pods, we started with what our guiding principles are. Really, the first one is democratizing data. We felt it's really important when you collect data from the community that data belongs to the community, not to us, the collectors. So really making sure that we acknowledge that, but are very specific in going back to the community and letting them have that primary role in interpreting and determining how that data should be shared. What does that look like? In doing this, it's a really tangible way to center the community's voice and build capacity in the community. So not only is it skill development for us as an organization and kind of coordinating and having these conversations, but really the goal is building community voice and power, and kind of building this sense that we're all data experts. We give data all the time. We are interpreting data all of the time. We might not think about it that way, but that's what we're doing. And our community members are experts in their experience in our community. So we're building those skills. It also needs to be actionable. So we don't want to share data and have a data discussion with community members just to check that box. It needs to be something that community members can take action from it if they choose. And I think, and this one comes really from our community health assessment process. We're looking at community headed data pods as an opportunity to continue relationship building with our community. That's really our primary aim, probably more than just the data discussions themselves, is we just want to constantly build trust and relationships. And so that is one that we're approaching these discussions, not looking for a specific outcome, which that's pretty tricky. But we're more wanting to be a listener and have the community decide what those outcomes are. So shifting our kind of way of thinking from maybe problem-based, which is a lot of times how we approach data in public health. We're looking at deficits, maybe not assets, and shifting it more to generative-based thinking, whereas with our community, we're discussing it, we're open-minded, we're sharing new ideas, we're identifying gaps, and then going from there.
All right, so let's talk about data pods as a concept. And this is not a unique tool or a unique process to this project. Data pod processes are things that have been used in community-based participatory research for probably decades, right? But in its simple form, really a data pod is giving the opportunity for community to look at data that's been collected to reflect their experience, and then to give them a process to kind of reflect on what they see, and then summarize what they're seeing, how they see it impacting the community, where they see voice coming from, who is missing, all of those pieces. And then also, considering how that information is going to be given back to the community. So again, it's just being true to letting that community voice again center on those three stages of analysis, interpretation, and dissemination. So really, the data pod process has participants in a community setting, giving some data for them to look at and interpret. And then really, as the researchers, we provide a variety of prompts to kind of guide that reflection of the data. I do want to say here, though, and I know we're going to talk about this in a moment, but one of the biggest decision points in this process is what data we're showing, how we're showing it, at what level of the process, of the analysis are we going to engage the community in? So are we sharing really raw data? Are we sharing data that's been partially analyzed? And so we're looking to kind of verify is our analysis on track? Is it not? Those types of things. These are all very, very important things to consider as you're thinking about the data that you're putting in and the prompts that you're going to use to engage. And then lastly, that interpretation is incorporated into the evaluation and the dissemination of projects. So I want to give you an example of some of the prompts that we've been using so far in the data pods for this particular research project. And I want to say that these prompts are really based on the reality that a lot of our data and intention of the study is to think about stories and connection between individuals, individuals in the community and the healthcare providers and systems. And so stories is a very big component of what we're looking at. And so you'll see that reflected in these prompts. So the prompts that we've been engaging with so far are: what story do you think this data tells? What's a story that you predict others might tell from this data? What story do you wish you could see in the data? So that's, getting at that. What do you not see reflected in your experience that we've shown in the data? And then lastly, what actions do you most want to see from this data? And that's when we're starting to get into that dissemination component. So again, data pods are not a new process or a new concept, but it's connecting the data pods with this intentionality of data equity that we really, are wanting to incorporate in this and other work that I know Rebecca and the staff at eHealth County are continuing to do.
And here's the hard part: the decisions. So there's not a roadmap. There's not a one size fits all. Here's how you do this. You need to make a lot of decisions along the way, and document them and be transparent with the community about the decisions you made and why. Because with each decision, we're inserting our own bias, and so we need to acknowledge that. But I also think it's important to take action, right? Change how we do things, but we still need to make those decisions. So here's kind of a list of decisions along the way when you're deciding to do a data pod, data discussion in the community, that you need to make an advance, anywhere from how you select the data, which I will tell you, with the community health assessment, that's a big challenge. Who's facilitating the discussion? That can also be a challenge. What format? Who you're inviting? Those prompts that Erin mentioned. A lot of that is based on how is this actionable? How are these discussions actionable? That helps you determine what those prompts are. But decisions, you really need to take the time to examine these and document them and then communicate them back to the community. So you can kind of own that.
Yeah, and one thing I'd add with this too, at these decision points, and Becca alluded to this earlier, that data, engaging community in data analysis not only is for the intention of centering community voice and making sure that we're really speaking the true or trying to get to, what best reflects what is actually happening in the community, but it also is a process to provide an opportunity for community to develop expertise in data and data analysis and feel good about that, right? And so what we don't want to do is we don't want to throw community members into a process where we're throwing very complicated data and we're telling them really long processes of how the data was collected, how it was analyzed. And so they're left sitting there with head spinning, and they leave that process feeling that they didn't contribute, or that they don't have the expertise to do that. We do not want that. And so it's really this balancing act, truly, of how do we engage communities in the most critical aspects of analysis and reflection, and yet provide an experience that is going to honor them and build their capacity. And so it's these decisions are important, and it's important to be transparent in how you've made those.
Lessons learned. I love lessons learned. When you start to really focus on centering the community's voice in all things data, that makes a lot of people really uncomfortable, because we're shifting how we typically have handled data. Typically we decide the questions we're asking, we decide how we're going to push it out to the community, we gather that data, and then we analyze it, we interpret it, and then we communicate it. And that's all done in a very small group of people that have a lot of power, really, over that community data. And so it is a little uncomfortable when you start to think about what this looks like when the community has a voice in all those different pieces of data. And it's important to kind of acknowledge, like, this is a shift in thinking, this is a shift in just how we operate. And so it does take we've learned it takes a lot of time for, if you're working with another organization, to kind of sell the idea. It takes a lot of time to have people feel comfortable in that space about how would facilitation look like, to really acknowledge that every community member has expertise in all things data. And so just don't shortchange that. There's some growing pains here when you attempt something new, but also are sharing some power when it's around data. I think the other thing is nothing's perfect. Anytime we're trying to change how we're doing our work, especially when we're incorporating community voice into that, sometimes people can feel like it needs to be perfect the first time, and you get caught up on the methodology, and then it limits you from taking action. And so it's just really important, like, just jump forward and take some action, and just make sure that you're reflecting, and it's that process improvement. What went well? What would you do differently? Acknowledge your limitations, whether that's capacity, funding, all of those things, and then, change how you do it the next time. But I think the important thing is just move forward, keep moving forward, and keep kind of learning forward as well.
Yeah. And I know we're short on time here, but just to say, as a researcher from an academic, brain, I guess, we're always challenged with having to describe the rigor in what we're doing, right? And I would say we need to turn that on its head. We need to think about rigor in a very different way, not from a method perspective, but really from a reflection and equity perspective. Is our process rigorous in a way to being equitable to the data, equitable to the population, and forget about did the methods provide this high level of rigor, and again, just be transparent in how you're describing what you did, why you did, and the decisions that you made in that process.
All right, real quick, some other maybe potential applications. It's actually some things that we have done. You can do this not only with quantitative data, but also qualitative data, or a mixture of both. The mixture of both is actually what we are doing with our community health assessment process. We're also planning with this federal grant to have a data pod with healthcare professionals specific to data we have collected from ethnographic interviews with healthcare professionals. So again, sharing that data back to the community that provided it and having those data discussions to interpret it and how we share it. And then we've also done it within our own public health team. So a lot of times our organization collects surveys from employees on different things. And, you know, we're really focused on improving belonging within our public health team. That's our goal, and also kind of workforce development. And so we have been doing data pods where we look at the data that's been collected by our organization from employees, and we have these discussions and we talk about, does this represent us? Do I feel that I'm represented in this aggregate data? How could this look different? So it's been a pretty powerful tool because all of our team members, again, are experts in data, even when maybe that's not their day-to-day job. So those are our current applications. I'm sure there's a million more. All right, I'm going to stop sharing. If you have any questions, you can always reach out to us. There's our contact information.
Absolutely.
Wonderful. Thank you both so much. What questions do you all have for Erin and Rebecca? Feel free to put them in the chat or come off mute. Seems like such an important topic because I feel like most folks involved in data or research are really looking at trying to better integrate community into their entire process. And so this is really fantastic. Some great examples and ideas on how to get that process started. I'm curious if you both have any recommendations in, you know, you kind of said like, just start somewhere, like start small, learn from it, move where you can. For folks that have challenges, we sometimes have challenges with getting other folks on board that maybe aren't used to or haven't thought about the importance of getting community involved in this process. Do you have any recommendations for how to get leadership or maybe even funders on board that maybe aren't used to this and really are looking for like the bottom line rigor points that you mentioned?
That's a great question. I think part of it is really, before you start on your project, having the discussion about why are we doing this? Who are we trying to center in this project or this data collection piece? Start there, have that group discussion because it's extremely powerful. And then also recognize what are our limitations to get to that, whether it's time, it could be skills, it could be funding. So you have all of that planned out in advance, but I found kind of that motivation piece is really helps to have that conversation, whether it's with leadership or funders, because you took the time to have that discussion to start with. It also helps to say, well, we also have a plan, right? So this might seem like, oh, it's a little, there's actually structure there. But you're also meeting the community where they're at and letting the community guide that process as well. We do have a federal grant that supported some of this work. I would say they've been very supportive in this process and also very interested in learning more about it. And with that grant, we've also had the opportunity to share how maybe some of the grant metrics we need to report back are challenging for us because it's a different type of project, right? We're not maybe counting the outputs, it's more of looking at the process as a whole as the outcome. And I think that's important to talk through as well, whether it's your funder or your leadership, what are your aims, building trust and relationship, that's okay to have that be an aim, in addition to having those data gathering outcomes.
Yeah, and I would add too with that. I mean, I completely agree with Becky that understanding motivation is critical, right? And I mean, even particularly with the members on the team. I mean, we did that collectively, and we sit in different places. There's academics who are at the table. There are community, local health department, Becky in the local health department, community organizations, all that had, when we brought it out, had slightly different motivations, right? And so we needed to make sure that we were going to center together on something similar, acknowledge the fact that we were coming from these places, right? But then also it's, kind of like developing a mission statement or something. We had to come to an understanding that we were going to go in this direction. So I think that's also a really important piece. And I'll say, when you do that, or even along the way, it's fascinating to know when little things will become apparent to those different agencies that we need to change things. And I'll use one example. So we were doing data collection, and to do data collection in any research agency, you have to go through an IRB process, an internal review process, right? And you have to identify how the process is going to protect the community, but then also who's going to be engaging in the data collection and analysis. Well, we intentionally use community members in that process, right? And for this project, we had, BIPOC community, those who only spoke Spanish. And to be a part of the research, you had to have the qualifications of taking a test, or basically like taking a test through the IRB, and that was only in English. I mean, there were little things like that now we're able to go back to our organizations and say, hey, we are not centering on we speak it, but then when we get down to the weeds here, we see there are problems. And so that one thing instigated a whole other kind of rollout of pieces. And that's just one example. We could probably come up with many along the way, but that's, again, it's continuing to put the equity at the center of what you're doing.
Great example and ideas. Thank you. There's also another question in here. I'm going to put some closing remarks as well in the chat, because I want you all to be able to answer this as we sign off. But how do you seize opportunities to qualify the data or crowdsource the data when the community qualitative experience is different from what the quantitative data shows? Great question.
Huh.
That is a great question. And I think that is what we are trying to achieve with our current community health assessment process. We're actually having multiple kind of data discussions. So we have started with just having kind of a community vision discussion. We're not going with data. We're not going really with an agenda. There's a fun activity. And it's talking about community and visioning a vibrant community and what we need to get there. It's very hands-on. It can be visual, it can be words, really meeting community wherever they're at. And from there, we're kind of coding that data, right? We are putting it into different themes. And at the same time, we're looking at our secondary data sources that exist around our community health indicators. And then we're kind of combining those pictures across those bigger themes. And then we're going back out to the community and presenting that data, right? The data we got from our initial conversations with community, in addition to the secondary data, and having conversations, kind of like those prompts Erin mentioned. What's important to what seems important when you look at this data, but also what is important that this data isn't telling you. And for us, I think that is really the question we've been asking ourselves for years, but we haven't quite figured out how to get there. I'm not going to say this is going to be the way. We'll find out, but it's at least a step forward.
Great. Well, thank you both so much. And thank you everyone for joining. You have everyone's contact information. If you have more questions or want to reach out, you can find the presentations on SCED as long as also with other things happening tomorrow. So please do join us tomorrow for the Emerging Leadership Showcase. And we hope you all have a great afternoon. Thanks, everyone.
Thank you.
Thanks.